Thank you very much for having me today. I think the last time I spoke here was on probiotics like 3 years ago or something. This is quite a different realm. I mean, that talk was mainly geared to outpatients, and this is geared to our sickest of inpatients, largely, and some outpatient management. In the interest of full disclosure, I do speak on behalf. I have given one talk on Sorafenib on Speakers Bureau. So the goals for this talk are the following. I hope that that you take away from this how to undergo surveillance for hepatocellular carcinoma and diagnose it, and as part of that, how to use imagery and alpha-fetoprotein. There's a lot of confusion regarding, and it's very complex about alpha-fetoprotein, and hopefully this will clarify some of the main points. And this disease really is complicated. I can tell you, and I'll try to make it understandable. And we have the benefit of having Dr. Berry here today from Interventional Radiology, who takes a special interest in chemoembolization for these tumors. And hopefully Dr. Atlori will be here too to sort of field questions on how the case report from this was treated in terms of chemotherapy. And then we'll talk about how to work up these patients, and particularly how important it is to get proper staging. I really am not an oncologist at all. I don't, as you know, this is a new area for me in terms of staging, but it is vitally important, and there is some disagreement in how to stage these, and as you'll see. But I hope you'll become familiar with what goes on in tumor board and how difficult, and appreciate how difficult it is to manage these very severely sick patients. And I must say, when all is said and done, it begs the question. I am not an outcomes researcher, but it is very, very costly to treat this disease, and I think therapeutic nihilists can make a very strong argument to, what are we doing here? It's extremely expensive when you're palliating these patients with Sorafenib. I'll show you that a very small percentage of people who do have hepatocellular carcinoma will benefit from Sorafenib, and give and lay out some territory as to where Sorafenib may be going in the future. So I'm going to center this talk around a patient that we just treated recently here within the last 2 years. This was a 50-year-old Mexican fellow who didn't know that he had significant liver disease, and he presented with abdominal pain to an outside hospital. And he was found to have a 10-centimeter lesion in his right lobe. He was referred to surgical oncology clinic here, and there the history was obtained that he had a history of Hep C and alcohol, and his alpha-fetoprotein was found to be 16,000. And when they calculated his Child's Pugh score, he was an A. Remember, Child's Pugh uses a combination of bilirubin, ascites, hepatic encephalopathy, and coagulopathy to determine that. So he was referred to VIR for liver biopsy, and during this process of workup, he represented with a massive variceal hemorrhage. And this failed endoscopic therapy, so a Blakemore tube was inserted. And I must say I'm greatly humbled in terms of my contribution, or lack of thereof, to this case. I basically gave up on this patient. There are a lot of learning points from this. So his repeat CT scan showed acute portal vein thrombus. Now, just stepping back and considering this case, I mean, anyone who has very little hair or gray hair in this room, how many would say that, this guy is basically palliative mode? I mean, I think, in honesty, anyone 15 years ago would say, like when we were in Michigan, the nurses used to say, give this guy a fishing pole and send him up north. I mean, this is a very, very sick patient, and I think, I mean, I'm the first to say that I think in 15 years ago we probably would have given up on this patient. Is that fair to say from among the majority of people? Yeah, I think I'm getting a lot of yeses. But I can just tell you that it still is very difficult in terms of managing. But there's been some progress in this disease, and there has been shown improvement in all-cause mortality in managing these patients. And today I'm going to take you through some scenarios about how the approach is evolving. And I can say one thing from this talk, that half of what I say here will be irrelevant in probably 2 years. If there's one thing I can say for sure, because this field is changing overnight, particularly in terms of interventional radiology's management of this disease. So this is the presenting CT scan, and I think even I can recognize that there's a mass here in the right lobe. You can also appreciate here that here's the confluence of the portal vein, and here's the thrombus in the right portal vein. Now that's key to recognize. I want to make the point that anytime somebody presents with any cirrhotic who presents with variceal hemorrhage, you have to basically prove that they don't have hepatocellular carcinoma. Okay? You really need to be vigorously seeking it out. And I can just anecdotally tell you that in 10 or 12 years, I've had patients who've presented this way, and I know they had a mass, but we couldn't identify it radiographically. But unfortunately, autopsy finds it oftentimes in the lung or elsewhere. But any decompensating cirrhotic, you need to search aggressively for a mass. Okay, and I think that's the learning point for the house staff. Okay, and particularly that they decompensate when they have portal vein thrombus for several reasons, and not the least of which is they have shunting within the tumor, so that the hepatic artery feeds directly into the portal venous system, and that's what really aggressively elevates your portal pressures. Okay, and they get just explosive variceal bleeding, and I think that's what happened with this fellow. So, as many of you know in this room, hepatocellular carcinoma is really rising aggressively here, and it's aggressively, and it's more so in men than women. It's about a 4-to-1 ratio. Smart oncologists, a lot smarter than myself, can probably say why that is. It may be an effect of testosterone, or do we know what the hypothesis is of that?
For the male predominant?
Yes.
Historically, it may be Hep C, other inflammatory liver disease-related discrepancies.
Mm-hmm. But it's interesting that
Later, but I think that recent data suggests that this disease is driven by Hep C, but also by other inflammatory liver states that
mm-hmm.
you guys see a lot.
But yeah, this rising curve is largely due, as Dr. Ash states, to the behaviors of IV drug use in the 70s, the rise, and particularly among Vietnam veterans, the prevalence of hepatitis C in Vietnam vets. Anybody have an idea? It's more than tenfold the rest of the population. It's over 20%. So I mean, IV drug use was just rampant in Vietnam era vets. Also, but more when University of Michigan looked at their explants for everyone who had hepatocellular carcinoma, 30 to 35% were from fatty liver. So this is going to be the epidemiology is changing, and fat will eventually overtake hepatitis C as an etiologic factor. So I'm sorry, I'll go another way. So worldwide incidence of hepatocellular carcinoma in red it represents very high zones, and yellow intermediate, and blue low. So in China, this is mostly due to hepatitis B, as in sub-Saharan Africa. North America and Europe is mostly due to hepatitis C, and that's important to remember because studies that are performed in Asia versus North America, Europe are not transposable because entry criteria are very different. When you're looking at hepatitis B patients, they tend to present much earlier in the course of their liver disease, so they can get, remember, hepatocellular carcinoma without cirrhosis, whereas hepatitis C, it's only with cirrhosis. So these are different populations. When you're looking at and evaluating clinical series or clinical trials, it's important to look at you know, what are the entry criteria, what are the clinical profiles of the patients in those trials. Okay, and I'll make that point again later. And this is just reiterates that point that Asian and African studies are largely hepatitis B driven, and North American and European and Japan are hepatitis C driven. And this slide's a little bit old. It's from '99 and 2003, but the other here is probably mostly fat, and that part of the pie chart is growing because of NASH. Okay, this is just a schematic of what happens, how you progress from risk factors to chronic inflammation, and then leading on to genomic instability to lead to hepatocellular carcinoma. A lot of resources are being expended now on the front end. Dr. Siraj can attest to that we're really trying to alter the natural history of this disease on the front end, and probably the outcomes people are going to tell us that, you know, our money is much better spent like on the front end with antiviral therapy, and I think we're going to be making a lot more headway with this when the protease inhibitors become common practice for hepatitis C, which is likely to come here in any time now in the next 6 to 12 months. And of course, it's also due to other bad behaviors of overeating and excessive alcohol use. So who's at risk? Who do we enter into surveillance? Which patient populations do we perform imagery on? And I want to make people aware of, you know, indirect markers of cirrhosis. You want to be looking for thrombocytopenia, and AST to ALT ratio rises not only in alcoholics but also in cirrhotics. Period. When that AST to ALT ratio is above 1, you want to be thinking this patient is likely has cirrhosis. And thrombocytopenia, when the platelet count drops below 125, the likelihood of cirrhosis goes up quite a bit. So cirrhosis from any cause, we are recommending regular ultrasounds, and alpha-fetoprotein is controversial. But with hepatitis B, it's a different story. Again, remember, because you can get the cancer without cirrhosis. So I don't expect everyone to know, but this is when we begin surveillance in hepatitis B populations. And again, hemochromatosis also, you can have cancer without cirrhosis. So these are surveillance guidelines from different governing bodies. EASL is the European equivalent of AASLD, and if you'll notice right away, alpha-fetoprotein is not even in the game with surveillance for hepatocellular carcinoma surveillance. The Asians are much more loose and fluid in terms of their the way that they survey their patients, and it's very interesting. We can learn a lot from them, I think. When you think about how we're detecting these cancers, you're basically taking a sonographer who has basically 2 years of training, right? They're taking about 8 or 10 images, still images, and then they're handing them over to a radiologist. And they're looking at these in, you know, not in real time, not looking for interfaces. And so there's a lot of operator variability in terms of the ability to see these. In Asia, the hepatologists themselves are conducting the screening. They're actually doing the ultrasounds. And I actually have met some practitioners in the United States who are of Chinese background who actually do their own screening. And I must say, I think that they probably do a far better job because they're very committed to this disease. And because of the high incidence in China, they're much more aggressive at trying to find these tumors, particularly because they can oftentimes have better outcomes too, because the tumors are found when the liver parenchyma is still preserved. Their underlying liver function is preserved, so they do better when they're detected earlier on. So, and then other governing bodies, including the VA, does still keep AFP in their surveillance protocol. And so, why is AFP controversial? And because it's both biologic, it's mainly biologic, because only the majority of tumors do express it, but a significant number do not express this glycoprotein. Remember, what is alpha-fetoprotein? It's expressed very high in the fetal livers, and in pregnant women it's quite high. There are confounding factors. Cirrhosis itself will elevate alpha-fetoprotein, and any chronic viral hepatitis or acute viral hepatitis will elevate it. There's some nice studies that were done in the 80s with persons who had e-antigen positive chronic hepatitis B, and their alpha-fetoproteins were quite highly elevated. The fibrolamellar variant of hepatocellular carcinoma does not express alpha-fetoprotein at all. And so, just to give you an example of different cutoff numbers for alpha-fetoprotein and what it does to sensitivity and specificity, pick your number, okay? So if you want to use 20, even with 20, that's very, very poor for a screening test to have sensitivity 41. It's extremely poor. And, you know, if you use higher numbers, your specificity does go way up, but your sensitivity is really bad if you use 200, for instance. And what patients and clinicians really care about, right, is positive predictive value, right? You want to know if this is positive, what does that mean that the patient has the disease? And that is relevant, of course, to prevalence. So of all comers who have cirrhosis in late stages, at best, your prevalence is going to be 20% in patients who have child C cirrhosis. So giving them the best benefit of the doubt, your positive predictive value is still only 61%, which is still pretty bad. So lest I beat up an alpha-fetoprotein too bad, I don't want to completely beat it up, because it is still used as part of the algorithm in terms of if you have imagery that's suspicious for hepatocellular carcinoma based upon its filling characteristics, then values above 200 are considered diagnostic. Okay, and I'll go over that later. So this is a schemata that's advocated by NCCN and has been adopted by other governing bodies as well. And this is the result of years of research in terms of applying outcomes data to surveillance. So if you have, and this is pretty much what a lot of centers do with small variations. So if you have a lesion less than 1 centimeter, you can repeat, usually because of cost, ultrasound. And then if it's stable over 18 to 24 months, you go back to every 6 to 12 months. Sorry. So if the lesion increases in size, then they'll fall over to this 1 to 2 centimeter realm, and with that, you're looking for typical vascular filling patterns. So what is a vascular filling pattern that's diagnostic of hepatocellular carcinoma? On dual phase or triple phase CT, you can distinguish hemangiomas from hepatocellular carcinomas because the filling pattern will be central and then fill outward on arterial phase, and then you'll have early venous washout. Okay, that's on CT. And with MRI, you can see on T2 weighted imagery, you'll have increased opacity. Okay. So if you have a lesion that's 1 to 2 centimeters, you like to see 2 imaging studies that are typical to bypass biopsy. And why do we not want to biopsy these patients? Well, for many reasons, because it can have considerable morbidity, but also in the literature there's a 2 to 5% chance of seeding the needle track. 2 to 5%. So anyone facing transplant or curative resection, you really want to avoid doing needle biopsy. I think this is news to a lot of folks. In fact, I just had a patient that we sent to Duke and really had a normal AFP, but had just a 2-centimeter lesion that we had been following for 2 years, but they went ahead and just and chemo. I think they chemoembolized it, or the RFA. I don't remember, but they went ahead and just treated that quite aggressively, without any biopsy and a normal AFP, because the imaging there was typical. If you have the imaging criteria goes down if your lesion's greater than 2 centimeters and your alpha-fetoprotein is greater than 20, and you have an imaging suggestive. Actually, even without typical features on imaging, if your alpha-fetoprotein is greater than 200, you can move right to treatment. So I'll just reiterate this again and say that your suspicion for cancer should also go up. Your pretest probability of it being a cancer should be higher in a child C versus a child A. And why is that? Because the annual incidence increases as the severity of cirrhosis increases. So your annual incidence will be 5 to 6% in a child C cirrhotic, whereas it's only 1% in a child's A, which is quite interesting. So again, if you have, just to reiterate again, because this is pretty complicated, if you have a lesion less than 1 centimeter, repeat imaging every 3 to 4 months, and if it grows to between 1 and 2 centimeters, I would definitely be getting MRs and CT scans and looking for typical vascular pattern to try to avoid this biopsy. But if your suspicion is high enough and you know that management is going to change, you still may consider biopsy. But at this point, when the lesion gets between 1 and 2, I still order alpha-fetoproteins. I must say I'm still stuck in that mode, although I may or may not be doing it. I'm curious, Hossam, are you still using AFP as part of your screening or your surveillance? And then again, just not to beat this over beat a dead horse, but if it's greater than 2 centimeters, you can use alpha-fetoprotein alone, or one imaging study being typical. But again, this is all to try to get around the biopsy. So what happens in patients who, what is the natural history of this disease if you don't treat it, if you do nothing, if you're a therapeutic nihilist? And these studies come from the late 90s. From this group in Barcelona, which is very, very active. And intermediate versus advanced, they define advanced as having extrahepatic spread or macrovascular invasion. Intermediate is you can still have bilobar involvement, but it's multinodular disease and it does not have extrahepatic. So it's basically the mortality is determined by that extrahepatic or macrovascular invasion. And as you can see, this is an abysmal outcome if you have advanced disease. I mean, 70 to 80% of people are dying within 1 year. If you have intermediate disease and preserved liver function, you can do quite a lot better. So let's get into staging systems. Okay. Most centers have accepted the Barcelona Clinic for Liver Center staging. And the reason is that with this disease, you need to incorporate into your working algorithm the underlying liver disease, the tumor size, and patient physical status, performance status, cancer-related symptoms, all of which appear to impact prognosis and treatment in the treatment approach. There are other systems that you should be aware of, and the French have their own system, which of course no one else uses but the French. So this is very complex slide. I'm going to show this many times during the talk because I think it really sums up what kind of is a working algorithm for what happens at tumor board. Okay, we consider, and it's a little bit confusing. I don't want you to know the details because the stages here can be easily confused with child Pew status. I don't want you to get that confused. But this working algorithm considers the performance status of the patient. It considers their child Pew scores, so the underlying liver disease. It considers the size of the tumor. It considers macrovascular invasion or not in distinguishing which which way they're going to go in their management. Again, it also considers whether or not they have portal pressure elevation or not as well. And again, as you can see, your only chance for meaningful long-term survival is surgery. Okay, so you really want to direct these patients to find them early enough that you can direct them to either transplant or primary resection. If Dr. Berry may differ with me a little bit on this, but I think that in patients who are undergoing chemoembolization or who are going to VIR, we really should be evaluating these patients in randomized controlled trials, because it's very controversial as to what we should be doing. It's very, very costly treatments, and they don't achieve a long-term meaningful survival. This is ripe for outcomes research, this area in here. Okay, as you can see, these survival rates are only 3 months when you have a child C-cirrhotic with a large tumor, and patients who are undergoing sorafenib alone, the median survival is like 10 months. But anyway, we'll go over this slide a lot. There's a lot in that slide, and we'll go over it again. And this just emphasizes again what are the different treatment modalities for the different stages of disease. Most patients, again, 80% are going to be in either palliative mode or basically going to be non-curative. And there's a move to sort of ferret these patients out into intermediate and advanced disease to try to determine which subsets of populations can do better with chemoembolization. So, looking at transplant, a lot of interest was in the 90s. This was highly looked at, and different centers around the world were trying to determine which size tumors, what happened to the size of the tumor and the number of tumors, and which ones were acceptable transplant candidates. So, Barcelona and Milan centers looked at their outcome, and they basically saw that whether, and I'm not sure what center that is. Bismuth, do you happen to know? I'm not sure either, but Lyon, France. Great, thanks, Tim. So one of the questions that was asked was 3 centimeters or 5 centimeters the cutoff, and basically they were equivocal with the 5-year survival rates, and so 5 years has become an acceptable standard due to this data, and also permitting 3 nodules if all 3 are less than 3 centimeters, and that's what you'll hear this in the literature, the Milan criteria for transplantation: 3 tumors all less than 3, or a single tumor less than 5. About 75% of patients will have 5-year survivals, and that's pretty equivalent to all comers. So again, going back to this Barcelona clinic liver cancer staging system, I want to now focus in on what are called local regional therapies, which is basically VIR, and this is chemoembolization. I'm not going to say so much for RFA, because RFA, and we're not really doing much ethanol injections. Are we doing that at all here? Yeah, this has largely fallen out of practice completely, and RFAs are adjunct therapies for either transplant or surgery. There is some research going on as RFA is definitive therapy, but it's not generally considered common practice. Chemoembolization is the area of interest, and so of all local regional therapies, you can do percutaneous ablations, you can do chemoembolizations, you can do chemoembolization plus or minus RFA, or radioembolizations. And Dr. Berry is our local expert in that, and he'll field questions afterwards if you have them regarding some of these modalities. So what is the data to suggest that chemoembolization improves outcomes? What happened is during the 90s, they looked at this as a modality, and it really didn't show improved outcomes. And what happened was in Spain and in Taiwan, I think this is Taiwan or Hong Kong, they found that if you defined certain subsets populations, if you avoided patients with macrovascular evasion or extrahepatic spread, you actually could show that treatment, that patients had favorable outcomes with chemoembolization. And that's shown here. The color, pardon this color schemata here, but in Barcelona, Hong Kong, the upper realm is the treatment arm, and these are patients who receive chemoembolization versus the control, no treatment. But if you look at these studies, they're fraught with error because like 90% of patients who were deemed ineligible, who had tumors because of extrahepatic spread, and 71 here. So there's a lot of this is not intention to treat analysis. It is, but if you look at who's getting excluded on the front end, it does raise some questions of purity in terms of how the studies were designed. But if you do, I think the improved outcomes in Hong Kong were probably due to, again, a larger subset, larger number of hepatitis B patients in this, so they had better preserved underlying function. Okay, as opposed to in Spain, it's going to be mostly hepatitis C. So what are the current guidelines as of 2010 with in the ASLD? They do recommend that you can still utilize chemoembolization in patients who do not have macrovascular invasion or who have asymptomatic multinodular tumors, no extrahepatic spread, and child's A only. Okay, you should avoid B or C's, and both governing bodies recommend avoiding B's and C's, and if you have any decompensation. Okay. And of late, there's a lot of interest in using drug-eluting beads along with chemoembolization because of this this data that's come out in 2009, 2010. This is conventional TACE. This is drug-eluting beads with TACE, and they showed that they improved 6 months mortality and 1 year mortality, and it was statistically significant. It did not benefit child C's, clearly. Actually, they may have even done, no, they didn't do any worse, but it did not benefit them. So in subset analysis across different, both in terms of child's QBs, there did seem to be a trend also towards improvement, but not enough to, they didn't give their, they didn't give their, well, they did give p-values for this, I'm sorry. But whether they had recurrent disease, bilobar disease, or ECOG performance status of 1, which is poorer than ECOG 0, they all seem to show a trend towards improvement. So there's a lot of research going on in terms of what is the role for drug-eluting beads plus TACE. So that's about all I'm going to say. Dr. Berry will say a little bit more about chemoembolization and what he did for our case patient. Going back to the schemata again, and I'm going to talk now about the role of sorafenib, which patients are appropriate for sorafenib. It really is a minority of patients. And this study was published in 2008 New England Journal. This was a multi-center study conducted in Mount Sinai in the U.S. and several European sites. And the data was collected in Barcelona. And what this showed was that the study was stopped early because at 14 months the survival benefit, significant survival benefit was demonstrated here. That median overall survival was 10.7 in the sorafenib group versus 7.9. This generated tremendous interest in the oncologic literature because this is the first agent that's shown a survival benefit in hepatocellular carcinoma. First agent ever. How does this thing work? It's a tyrosine kinase inhibitor. It works through ERK pathway and blocking both in limiting tumor cell proliferation as well as limiting endothelial cell proliferation. It both works by blocking paracrine stimulation of endothelium and by blocking tumor cell proliferation, and also by disinhibiting apoptosis here. So it also, a softer endpoint in the SHARP trial was a time to tumor progression, and it also showed that this drug does not destroy the tumor. It basically stabilizes it by choking off its blood supply. You don't get and basically this led to recommendations from guidelines from the various governing bodies, including the ASLD, that patients who are candidates for this, again, are only Child's A, which are a minority, a vast minority of patients are candidates for this drug. You have to have well-preserved underlying liver function. You should have macrovascular invasion or extrahepatic metastases. In subset analysis of SHARP, interestingly, the patients benefit who would also receive local regional therapies. Okay, so a lot of interest is going on now using combinations of TACE plus Sorafenib. There's a lot of ongoing trials looking at the combination. And so again, I hate to, this is like the fourth time I presented this, but it really is a very good working schemata of what goes on in tumor board in terms of organizing the thought process. And so going back to our patient, our case, index case here, what do you think? First of all, does anyone see how we may have done, how we could have managed this patient a little bit better on the front end? With an alpha protein of 16,000, and somebody with these risk factors, did we need to do a biopsy? You really don't need to do a liver biopsy. You really should not be doing liver biopsies, actually. Okay? Which is really a change in management, really a change in thought pattern. You know, as we just had a case this morning, we presented that it's really hard to find definitively, even in core biopsies, to find the tumor. I've had patients that I knew had cancer. I biopsied them twice. This was 10 years ago. Couldn't find the tumor, and they died a couple months later, and they had massive pulmonary metastasis. I can't say that enough. One of our GI lab nurses, I don't want to have a HIPAA violation, but she was recently transplanted, and they found within 1 year she had a right atrial thrombus, which was a malignant thrombus. So they can be very difficult even to find at the time of transplant. So the other points to make in terms of the management of this patient is don't give up just because they have massive variceal hemorrhage. That can be due to shunting within the tumor itself again. And I think at this point, any questions from me in terms of what's been said so far? I want to have Dr. Berry say a few things about how we manage this patient, because even though there are algorithms and these are guidelines, I want to share with you that patient is still alive today. Can you imagine, 10 centimeters, he's now 15 months out. And Dr. Berry, Dr. Lurie, and Dr. Zervos have done a remarkable job in treating this patient. I mean, I honestly, I gave up on this patient, and it was a really humbling learning experience for me to see what can be done in this disease, as abysmal as it is. Any questions for me that I can field regarding Tim?
Mark, that was a great presentation, and thanks a lot. I wanted to go over that, as you know, and everybody in the room should know, that all these modalities are available at HCC. There will soon be opening a prospective randomized multi-center trial looking at Sorafenib plus or minus Chemoembolization. So we have, as you said, those patients should be going on trial. We have the ability to do that. Having said that, Mark, we kind of felt like a stab in my heart when you said we sent this patient to Duke for radiofrequency ablation. I just want you to, for the people in the room, maybe tell us which patients are the folks that we can't manage here in town that ought to be referred to another center.
That patient had a MELD score of like 15 and was under surveillance for liver transplant.
So liver transplant
yep.
would be the only indication to send somebody elsewhere for hepatocellular cancer?
Yeah. Yeah.
Thank you.
But again, I mean, surgery surgery is your only. I mean, you want to find these people early, and transplant is your best outcome in this. Without question, transplant is your best option for these patients. If you have macrovascular invasion and that patient gets resected, even if they're Child's A, there's about a 60%, 70% 1-year recurrence rate. So you have to be very careful in selecting which patients go to surgery. Okay, but in fairness to the surgeons, in great fairness to surgeons, it is extremely difficult to determine what is macrovascular invasion or not, because you can't tell whether that's a malignant thrombus or a thrombophilic thrombus. It's extremely difficult. Can you say something about that, Hassan? But
Any other therapy rather than transplant is a bridge therapy. So it should go side by side, and I think a patient like this, if he's stabilized initially, should be in a center where transplant is available. But at the same time, we know the waiting period and so on, and if of course he will be upgraded and he will be on the waiting list on an upgraded status and have priority. If a patient like this, yes, I think bridge therapy is done with a bad space or so, but transplant should be available.
Yeah, I think I agree with you that partnering, I think the best care is local care, with partnering with somebody who can do transplant if necessary. This guy with a 10 centimeter right hepatic mass is never going to be a candidate for
And even
transplant.
if initial therapy is successful, and we saw that there is improvement, this is again not a definitive therapy, and even after successful local therapy, he will have to be on transplant evaluation and diagnosis.
I think that outcomes researchers are going to have a lot to say about this as well, because I think to get one quality adjusted life year out of this treatment is going to be very, very expensive. In terms of Sorafenib use, it's probably in excess of 200,000 probably, because basically you're spending, what is it, about $9,000 a month to treat these patients to get 3 extra years, to get 3 extra months. Remember, the mean survival in the treatment arm was 10.8, and it was 7.9 in the in the placebo arm. So again, unfortunately, most patients in the United States are child C with B or C cirrhosis. So I just want to reiterate again that this drug is only indicated for child A cirrhotics at this point. Okay, and they're the minority of patients who are diagnosed under surveillance. Okay, most of these patients are at transplant centers already because of their underlying liver dysfunction. And I want to make that point again clear, that you don't, when their MELD scores, right now, what was the listing criteria at Pittsburgh for MELD score? Was it 15?
15 is the least, the minimum criteria for this. The time for transplant, at the time of transplant, the average MELD score is between 25 and above.
So basically, my practice here now is to keep patients here. I don't send them to a transplant center yet unless their MELD scores exceed 15.
Of course, unless there is.
Yes, unless you find a cancer. Exactly. Okay.
Mark,
Yes.
one question.
Yes.
Great talk. I want to go back to the screening tests that you said. There are a lot of patients here who obviously, uninsured, coming from a faraway distance. Very difficult to screen them with ultrasound and any other imaging modality. I usually use AFP for whatever work it has. Do you have any specific criteria in which where you say, oh, this patient must be followed by ultrasound? For those who are asymptomatic, chronic hepatitis C, chronic hepatitis B, stable patients, and you're following them, maybe you failed therapy or couldn't get therapy because of a number of reasons. Unless they decompensate or unless they have a very advanced disease, for those who are very stable, asymptomatic patients.
Well, that's a great question. It's a whole talk in and of itself in terms of how to diagnose cirrhosis or how to screen for cirrhosis. Now, there isn't a great literature on screening for cirrhosis. It's very difficult to determine who has early cirrhosis. We use indirect markers, again, as I suggested, thrombocytopenia, and this AST-ALT ratio can give you a clue. But that's why we're very vigilant about finding out which of our hepatitis C patients have cirrhosis and trying to find out that early on, because those are the ones you're gonna undergo surveillance. All patients who have hepatitis C, you're not going to be screening. You're not going to be. I'm sorry. You're not going to be entering them into surveillance. So you needn't worry. Like if their platelet counts are 200,000, you're not going to be looking for hepatocellular carcinoma in that patient population. Generally, so. But in your hepatitis B patients, I outlined the criteria, and I can go over those with you again. It's a whole different ball of wax. Does that kind of answer?
Recently, I have seen a couple of hepatocellular carcinomas where I would say I was not expecting them in terms of those results in thrombocytopenia and symptoms and liver biopsy results and things like that. So I'm just wondering whether I should screen more aggressively by imaging study, much more so than
in the absence of hemochromatosis, I don't know of any case report of hepatocellular carcinoma in hepatitis C without cirrhosis. Has there been any case report that you know of?
Even in NASH and yes.
Yes.
We talk about case reports.
It's rare.
What is the guideline?
Right.
So of course, if you do that for hepatitis C, if there is cirrhosis, how you diagnose it, you put it very right. It can be compensated cirrhosis. And even liver biopsy, there is a sampling error. So there is room for error for everything. But when there is cirrhosis, that's when you start surveillance in hepatitis C. And you can diagnose that by imaging and maybe clinical or lab.
So with that, I would like to invite Dr. Berry to come up and share with you how this patient was treated in terms of chemoembolization.
Thank you. So he is kind of an unusual case as he presented, unfortunately, in a non-stable fashion. He initially was seen in the tumor board due to the fact that he had right portal vein thrombus. The decision was made to make him non-operative in terms of his candidacy, then had a massive variceal hemorrhage, which basically no one expected him to survive several weeks later. After that, he had a protracted course in the ICU, managed to recover, surprisingly, and went home. And thereafter, the consultant surgeon, Dr. Zervos, requested that we embolize his tumor because he was concerned about a shunt. And we were all kind of a little bit doubtful of that at first because we thought basically he had varices and typical variceal hemorrhage. So we re-imaged him afterwards, and he was started on Sorafenib during this period because he was known to have HCC. And in the period of time after his variceal hemorrhage, he developed basically occlusion of the right portal vein where that thrombus had been. And you see a little bit of small recanalization going on here, but basically the portal vein ends right here. And the mass itself had undergone a humongous amount of necrosis, although obviously with active tumor still around it, as you can see down here as well. So clearly he's responded probably to a variety of factors. Probably when he was hypotensive due to his bleed, he underwent thrombosis of that portal vein due to the fact there was already thrombus there. And the starting of Sorafenib as well, it probably depleted the vascular supply of this tumor and it underwent spontaneous necrosis. Unfortunately, that tumor is not dead and is quite alive in multiple areas. Now, one of the key things to be aware of on these images here is in this picture over here. And this is the left portal vein, that's the aorta, and this is recannulated right portal vein within the right hepatic lobe. And the key thing to see here, it's a little bit inobvious here, is that the portal vein attenuation, in terms of the amount of contrast in it, is lower than the aorta, as it should be. This is early phase imaging. But the right portal vein matches the aorta, which indicates essentially this is an arterialized right portal vein. There is arterial shunting in this. The tumor has essentially recruited the right hepatic artery to keep itself alive. So he was sent to me basically to prevent a second life-threatening varicose hemorrhage, knowing that, you know, basically his long-term outcome with this big a tumor is very low. Tumors of this size tend to have very poor survivability. Beyond, you know, the typical criteria, even with chemoembolization and other things, tend not to do well. So he was sent to me, and unfortunately for him, he also has a very small body habitus and rather bad median arcuate ligament syndrome, which basically, if you're not familiar with it, means the celiac, the base of the celiac here is almost occluded with horrible stenosis. So what this is basically is a right common femoral approach arteriogram, and the catheter is coming up here. It's in the celiac as far as we can get it, and this is a celiac arteriogram, just a little review of anatomy. So left gastric artery here, splenic artery here. This is the pancreatica magna. These are inferior phrenics coming up here. Common hepatic, left hepatic, right hepatic. Now, one thing you note, the GDA is very poorly seen, and this is probably the GDA here, gastroduodenal artery. And the reason why it's poorly seen is flow is not going out the GDA, flow is coming in the GDA. And what that is due to is two things. One, he has stenosis down here, and two, he has this. So the hepatic arteries on an arteriogram like this should basically be really well-defined black lines. And what you see over here in the lower right hepatic lobe is you see a kind of a tram track look. You see a big fat line and a little skinny line. Well, the little skinny line is actually the hepatic artery. The big fat line is the right portal vein. So that is an arterialized right portal vein right there. Up here you see again, this is portal vein filling out here, portal vein filling out here, portal veins filling all over the place, actually in the hepatic lobe. So essentially, his tumors created an arterial to portal shunt, which is basically the reason why he presented in the first place with this massive hemorrhage. Lucky for him, the one thing that saved his life is the fact that he did have right portal vein thrombus, which completely occluded. Otherwise, he probably would have died. So he, by random chance, survived this horrible bleed. So this is his first presenting arteriogram, and unfortunately, on this day, we were not able to treat him due to his stenosis, although we did get really nice pictures. However, we did come back later on. I'm sorry, wrong slide. Shortly later on, about a week later, we're able to get through his stenosis and get a catheter out into the right hepatic artery, which is where the catheter is out here. And at that time, we did what's called a gel foam embolization. Now, gel foam is a short-term embolic agent, lasts for about 6 weeks, and then basically it's broken down. It's kind of a nitrocellulose type thing. And the point of doing a gel foam embolization in him is twofold. Basically, his only hope for therapy was sorafenib and possibly chemoembolization. And there's some discussion of could he be downstaged as well. And so what the gel foam does essentially is during the 6 weeks of time where the right hepatic artery is occluded, and this is post-gel foam, you see the portal veins have basically disappeared for the majority of these branches. The gel foam basically blocks everything off, allows those shunts to close off, and then allows the hepatic arteries to be recannulated thereafter. But the connection to the portal vein, for the most part, goes away. Now, one thing you will note here, and this is a very characteristic finding, this big blob right here in the middle, that's not an artery, that is what's called a venous lake, a very common finding in HCC that we see typically during our embolizations, and it's pretty diagnostic, honestly. So he underwent a gel foam embolization, did well, and then afterwards we set him up for basically a drug-eluting bead therapy using 50 milligrams doxorubicin loaded on these little tiny beads. They're 100 to 300 microns. And the idea of this basically is now that we shut the shunt down, we no longer have to worry about the beads flying out into the circulation as they can under that situation. And it's time to actually treat the tumor with something that's cytotoxic, not cytostatic. So the doxorubicin beads, or these guys over here, the red ones, these are irinotecan. What these beads are basically are little tiny beads of some complex plastic polymer that absorb the chemotherapy into the bead, and once they're implanted in the tumor, they elute the chemo over a period of time up to about 6 weeks. And what that does is give a very high local dose to the tumor. So 50 milligrams of doxorubicin into this tumor is probably equivalent to 5 times that systemic dose, if not higher. And so you get really to a cytotoxic level of chemotherapy directed directly at the tumor itself without the systemic side effects. Admittedly, eventually all the doxorubicin is going to pass systemically and it's going to be gotten rid of, but it's going to be in a much slower fashion than if you give them a mega dose. Just for the information, these therapies, even though they are expensive, honestly, a chemoembolization is probably less than 1 month of sorafenib. in terms of overall price. So it's substantially less expensive. Now, radioembolizations for HCCs are done as well. That's a significantly different ballpark in terms of expense, but these are not prohibitively expensive procedures. Also, these irinotecan beads are used for colorectal carcinoma mets in a very similar fashion. So day of treatment, basically we have embolized everything. Most of the blood supply is shut down. You are seeing some portal vein filling in some of these areas, which is not an unexpected or negative finding. And basically he had a pretty good outcome. And well, here's our venous lake right up here, which is what we see. It fills up with beads. Basically, that's not a negative thing either. So there is, and actually one interesting point, if you notice our catheter, instead of going down towards the leg, is going up towards the top of the body. He had to be treated from his arm. His stenosis was so bad that we had to go from the arm as an approach. Not a good approach, but doable. So after drug-eluting bead therapy, this is him, this is his tumor. We see basically all the surrounding enhancement that we had seen before is resolved. So he's had a very strong response to his drug-eluting beads. The cytotoxic doxorubicin, in addition to his sorafenib, has had a very positive response. His tumor basically has responded well. I don't have all the pictures, but basically the vast majority of this tumor is now necrotic. So at this point in time, basically the decision was made to consider an operative management. He was still restrained to the right hepatic lobe, and even though he had portal vein thrombus at one point in time, basically it had been stable and his right portal vein essentially no longer existed. I think we're done there. So he did go on to surgery afterwards. So Dr. Zervos had a resection. Has actually done quite well afterwards. It remains in sorafenib to this day. So, any questions while I'm doing my little section here? Yes?
Oh, I just wanted to make 2 points, and things might be great for June. Sorry, I missed it earlier. One, I think that, even though, sorafenib alone as a sharp trial, the benefit is approximately 3 months, especially at ASCO 2010 last year, there were several abstracts with, incorporation of XBAR sorafenib, that is, with Case and other local regional therapies, which I think with time we'll be able to see that are impacting, hopefully overall survival as well as progression-free survival, and we'll see that it's going to be longer than we think. And I think the other point I want to make is that, the care of this patient is a perfect example of the importance of having multidisciplinary care. I think that, without the cooperation of GI group, the surgeons, at every point of the way we reevaluated and pushed this gentleman's care to the, limits. I mean, I think we really pushed the envelope here as far as offering him every single modality that we could, and have gotten him to a point where his initial AFP was about 200,000, and right now it is maintained at 13. So, without multidisciplinary care, we would not have been able to manage this patient in this fashion, and it speaks for what we're trying to do at the Cancer Study.
Completely agree. One thing I actually would note, the slide we looked at earlier is showing the chemoembolizations and outcomes. Those slides are basically from the 90s. The chemoembolizations done back then are substantially different from what they are today due to the fact that we have completely different drugs that we use, and delivery systems are very different. Even for what's called classical chemoembolization today is very different from what they did in the 90s, and especially over in Asia. So that data all should be taken with a grain of salt in terms of outcomes and everything else. Okay.
The patient now is, what is the transplant option for him now? Is he a candidate for it, or has he been evaluated?
Tim, do you have any input on that?
I'm not familiar with this particular patient. If he's got preserved liver function at this point, I don't think there'd be a strong indication for transplant unless he had recurrent disease. Coming from Pittsburgh, you probably have a better sense of that, but if he's got no evidence of disease, and he's a child, A, cirrhotic, not decompensated, I would imagine he'd be very high on the transplant list. Obviously, if he has a recurrence of hepatocellular cancer,
patient like this would be on the transplant list at the same time. But of course, you know the patient better, but this is the Pittsburgh image.
I think it's great. And we see a lot of hepatocellular cancer here. And I think partnering with somebody who can do a backup liver transplant is important. You have 2 centers in the state that have real, 3 centers in the state that have very high volume liver transplant programs.
Any other questions?
And let me also ask,
Yeah.
what was his bilirubin level before we did the test?
I don't recall. I think it was normal, honestly. Typically with TACE, you use 3 as a cutoff, and he was below that. So, I mean, he had pretty normal biliary drainage at that time. Now, you know, after TACE, bilies can go up with the necrosis you get in the tumors and everything else. And it's really hard to say exactly what's going on in that situation. Sometimes, you know, there can be some degree of biliary obstruction, but sometimes it's just the breakdown of tumor, and sometimes there's failing liver, essentially. With these, he, due to the fact he had such a large right hepatic lobe burden, got basically a kind of a low bar treatment. Now, we can be extremely super selective with these treatments if necessary. In fact, Christmas Day this past year, I treated somebody who had a spontaneous hemorrhage in their abdomen from an HCC, and an 80-something, 85-year-old woman, I think, who was basically going to bleed to death unless it was treated that day, and I treated just the tumor. We had one artery going to it, and I treated just that tumor. She did really well, no bilirubin issues or anything else afterwards, and actually her AFP has come down on Sorafenib now and quite stable. So, you know, in terms of your question overall, he had a fairly normal bilirubin on presentation. I believe it was 1 or somewhere around that range. And I think since that time he's had some elevation of his bilirubin, but the question is what does that do to, and I don't think that's quite resolved yet. So, any other questions?
I think in my hour we'll take the rest of the questions down front. Thank you.
Thanks.
Hey. Your page this morning.
Oh, yeah. I didn't realize you were on nights.
That's okay.